Hi, everybody. I'm Dr. Koci. Today we're going to talk about large vessel vasculitis. And where we're going to focus is Takayasu's giant cell. So we're just focusing on this spectrum of vasculitis, although you have medium vessel vasculitis, ANCA vasculitis, small vessel vasculitis. So we're just going to focus on large vessels and the more common ones. All right, so let's start with a question. Somebody wants to volunteer? Don't all volunteer at once.
Patrick, volunteer.
I'll volunteer. A 77-year-old woman is evaluated in the hospital for a 2-year history of arm aching that is worse with lifting, hip aching that is worse with walking, morning stiffness lasting for more than 60 minutes, and malaise. 2 weeks ago, she developed progressive dyspnea. She's had no chest pain or back pain. On exam, her temperature is 100 Fahrenheit, her blood pressure is normal, but she has a 14 millimeters of mercury difference in systolic between her left and right arm. She has no rash, she has no temporal artery tenderness, but there is a bruit heard over the right supraclavicular fossa. Her right radial pulse is reduced. She has a diastolic decrescendo murmur at the upper right sternal border with bibasilar crackles on auscultation. And then she has painful range of motion in her shoulders and her hips. She's no joint swelling, and an echo shows that she has some AV regurgitation with normal leaflets and a dilated aortic root and dilated left ventricle. Which of the following is the most likely diagnosis? Infective endocarditis, subcranial giant cell arteritis, granulomatosis with polyangiitis, or Takayuso arteritis? And I would guess D.
Okay, how did you get to that answer? And
so I think she is the risk profile. And then from her history, she has systemic symptoms, which aren't necessarily. She has systemic symptoms, including her proximal muscles. She has morning stiffness, suggesting an inflammatory state, and then she has this low-grade fever, and then she has the systolic difference in her upper extremities. So, and then on the echo, there's no evidence of. I know it's only a transthoracic, but there's no evidence of infective endocarditis. She doesn't have any of the temporal tenderness. So that's why I was leaning against the giant cell arteritis. And then it doesn't sound like GPA to me anyway, but she does have some lung crackles.
Because so this history of arm aching, right, with lifting, and they say there is a bruit heard on the right supraclavicular fossa. You're thinking there might be some sort of stenosis, something going on in those vessels, right? That's why you're going with Takayasu's here, right? Or do you want to think of giant cell maybe?
We have some other people in the chat. So some people are guessing B because of the younger age. Then some people also agreeing with Patrick saying D. So it's 50-50 between B and D. But the people people who are going for B are going because of the age.
Age, right. So the age here plays a major factor. That's why this is giant cell arteritis. But yeah, D is also a good thought, and I'm glad nobody picked C and you also ruled out A. So the age is the main factor here, says giant cell arteritis occurs in one of the criteria is for the patient to be on the elderly side, so above 50 years old. And with Takayasu, we're thinking of a young female, right? Less than 40, which is why this is more like GCA, not Takayasu. What threw you off here is that this is subcranial vessel involvement. So we are always told that, think of temporal headache, right? Like this one-sided headache that's new, that's severe, but it can also occur in other vessels in addition to the temporal arteries. So I think that was the trick in this question. So it's B, subcranial giant cell arteritis. Okay. So it goes by different names. Giant cell arteritis, also called Horton's disease, is the most common vasculitis. Again, it can involve large vessels, even medium vessels, but remember, it can affect different extracranial vessels. One of the criteria, like I mentioned before, the patient should be above the age of 50. So it's in the elderly. Every 10 years, so if you go from 50 to 60 to 70 to 80, the chance that somebody can develop giant cell arteritis goes up significantly by almost 10% every 10 years. So it's extremely common, found in the 80, 90 years old. There is a report that it's more frequent in white population, especially Scandinavian, but you can find it in any ethnicity, really. It's more frequent in females, about 3-to-1 ratio. I don't know why, but, and also think of those PMR symptoms. So stiffness of the shoulder, stiffness of the hip girdle, which gets better as the day goes by. So those are some of the features of PMR, which are associated with GCA. So up to 50% of patients with GCA also have PMR. So if you have a patient that you think they have PMR, also screen them for GCA. So think about those features like temporal, the headaches, the jaw pain. So because of this frequent association, and if I have somebody with giant cell arteritis, I'm always asking them if they have any PMR features, whether it's for a new diagnosis or for follow-up appointments. And sometimes the problem here is that all these patients that you are going to see who have GCA, they're elderly, right? So they are in their 70s, some are in their 80s. Chances are they have shoulder osteoarthritis, they have rotator cuff tears, and I had a patient who had rotator cuff tears on both shoulders. I tried to convince him to take prednisone. He wouldn't. He said, it's my rotator cuff. I have spinal stenosis. I don't want to take prednisone. He comes back 2 weeks later with headaches. Now the PMR, what looked like PMR, had become clear GCA, and the patient was diagnosed with GCA. So just be careful in the patient population. The key word is new. Is it a new shoulder stiffness, or is this a pain that you had for years? So new shoulder stiffness, whether they have rotator cuff tears, whether they have osteoarthritis of the shoulder, should raise an alarm. So as far as features, if we examine the temporal artery, you'd have usually during the flares, it becomes prominent. You have a decreased pulse. If the ophthalmic artery is involved, those patients will have decreased vision. They might have amaurosis regax. They might have diplopia. So at that point, if the vision is affected, you should get ophthalmology on board to evaluate these patients to see if there's any swelling of the optic disc, like there is in this picture here, if there are these flame hemorrhages. And in this case, that's where an ophthalmology referral will be necessary. But if a patient doesn't have any visual changes, you might not need an ophthalmology referral. Another feature you might need that you'll notice is this jaw claudication. Now, what exactly is that? Patients can describe it as jaw. They might say, well, my jaw gets tired. And the case that I described earlier of the patient who had rotator cuff tears in the shoulder, who refused to believe he had PMR and then GCA. that's how I noticed that when he came for the follow-up appointment, he was endorsing that when chewing, he said his jaw would get more fatigued than before, right? So that's one of the presentations. Some people describe it as a cramping of their jaw, but usually it's when they chew food, they'll have fatigue or some discomfort in their jaw. Sometimes it can be the tongue. You can even get ulceration of the tongue or changing taste. So that's also another feature of GCA because it does involve the facial artery, right? So everything that's affected by it will comes off. All right, so now as far as other symptoms, you have constitutional symptoms, the weight loss, the low-grade fevers, overall feeling of malaise, fatigue. If there is any suspicion of vasculitis, make sure you check the blood pressure. You should check it on both sides of the arms because as we noticed in the case prior, there was a bruit there. A lot of times you see a discrepancy in the pulses in the upper extremities, but sometimes it's a good idea to check it in the lower extremities because vasculitis doesn't follow the book to say, you only have it in these vessels. You can have it in any vessels. You can have it in the lower extremities as well. So if you suspect vasculitis, you are not sure what type of vasculitis it is. May check the pulses in all the extremities, check temporal arteries, right? So blood pressure should be checked in all 4 limbs. PMR features, like we mentioned, stiffness of the shoulder, stiffness of the hip girdle. Sometimes patients will have discomfort around the base of their neck. Now, why do they have stiffness around the shoulder? Ultrasound of the shoulder and in the hips of patients with GCA has shown some subacromial bursitis. So maybe it's the bursitis that presents with that has those features of shoulder on both sides, right? And also trochanteric bursitis. So those are areas where you want to palpate and examine to see if there's any increase in tenderness. All right, so we have some criteria for giant cell arteritis, but these criteria are made to classify patients for research studies. So I wouldn't limit myself to the criteria. So these are classification criteria, not diagnostic criteria. For diagnosis, think of an elderly patient with symptoms of malaise, the PMR, like we mentioned before. So as far as the frequency of symptoms, new onset headache, remember the key word is new headache, jaw claudication, new stiffness, visual symptoms, all those things should be a red flag. Limb claudication, again, it can happen in other vessels in addition to the temporal arteries, but again, less frequent here. They say up to 10%. As far as workup, you want to check the inflammatory markers. So both ESR and CRP should be checked, and they should be high. These patients are elderly. The majority of elderly will have a slight increase in their inflammatory markers, but this should be a marked increase in the inflammatory markers, not just barely positive. And there might be case reports, and there are case reports of GCA being found with normal inflammatory markers, but those are rare. That's why there are case reports, right? So if we're thinking of a typical patient with GCA, you'd expect a high ESR, high CRP, and CRP is more specific than ESR because some patients may also have MGUS, they might have CKD, which also affects the ESR, anemia, and other conditions. So the CRP is a little bit more specific. You might see normocytic anemia as well, reactive thrombocytosis, fatigue, malaise. All those things should be taken into account when you make the diagnosis. Now, if you suspect GCA here in our practice in the United States in general, you want to get a biopsy. That's how we confirm. We confirm GCA with temporal artery biopsy. The size should be on the side where you have the symptoms. If you don't have symptoms on the other side, there's less likely this will come positive, but if you do it on both sides there, the sensitivity goes up, not significantly, maybe 5 to 10%. However, if it's negative on both sides, the chance of this being GCA is much, much lower. So then in that case, you can decrease the prednisone, right? Because that's what you do. You think there's GCA, you give high dose steroids. Biopsy comes back negative, you taper off the prednisone. And if you think the patient has, in that case, the patient might just have PMR, right? So in that case, you give low dose prednisone. So if we get the biopsy, what you'll find, the typical finding where the name originates is giant cells. And then these are found in the middle of the internal, on the tunica media here. Internal elastic lamina will be affected. So usually there should be staining for the internal elastic lamina. So if you see an interruption there, that's what tells us that there is inflammation. But again, you don't necessarily need to see an interruption in the internal elastic lamina to make the diagnosis. Infiltration with lymphocytes will point towards it. Now, in Europe, they have a different protocol. They like to do the ultrasound first before they do the biopsy, and they avoid the biopsy if the ultrasound shows this positive finding. So in the bottom, we have a normal ultrasound. You see a patent vessel here, and on the top, we see a reduction in the vessel lumen here, and there is this hypoechoic area around, which is the inflammation of the vessel, right? So this is non-compressible, and it has the sensitivity and specificity of ultrasound vary depending on the operator. If you have a center where they scan patients all the time, they have a protocol, the radiologists are trained, the technicians are trained, you'll have a much better result than in a center where this don't get performed very frequently. So from the people who do this frequently in Germany and Austria, they get temporal artery ultrasound, but also an axillary ultrasound to look for these features of halo sign. All right, another question and another volunteer.
Anybody volunteering before we volunteer?
Cardo, how about you?
Sure. Sorry, I just need to keep the camera off for a bit, but 79-year-old man is evaluated for a 2-month history of progressive malaise and weakness, aching bilateral shoulders and hips, and stiffness for 2 hours in the morning and after immobility. He recently noted aching in his jaw when chewing. He also reports new left-sided headaches. Last week, he had an episode of diplopia lasting 1 minute. On physical examination, vital signs are normal. Tenderness and slight swelling over the left temple are present. Painful and limited range of motion of both hips and shoulders is noted. The remainder of the examination is unremarkable. Lab studies show ESR of 85. What is the most appropriate next step in management? So I think that's part of what we were just discussing in one of the questions that Mantesh had. Option A, low dose aspirin, B, glucocorticoids, C, temporal artery biopsy, and D, tocilizumab. So this patient sounds like he has clear symptoms of PMR. And he also has ocular vision, so that's urgent. So he should be started on steroids. So I think option B.
Yes. Yeah, so with vision changes especially, right, he should be started on steroids ASAP. What about low-dose aspirin? Should these patients be also treated with low-dose aspirin? The data is not there, right? So, you know, some practitioners might say, you know, let's give low-dose aspirin for primary prevention, but there's really no clear data whether it's beneficial or not. And what about the temporal artery biopsy? Should we wait? Well, obviously no, right? Because we don't know when that will be done. And even if it's done the next day, if a patient has vision changes, you don't want to wait. They can lose their vision on one eye, they can lose it in the other. So definitely start the glucocorticoids ASAP. In the meantime, contact vascular surgery and schedule this patient to get a biopsy ASAP, right? And yeah. And as far as tocilizumab, should tocilizumab be used? That's a steroid-sparing agent. But again, by the time the patient gets tocilizumab, the steroids should always be on board. And whether you add tocilizumab on board or not, the first step is always giving prednisone. Right. So let's say that you treat this patient, you diagnose him with GCA, you treat him with steroids, they respond very well. So you see them in the follow-up visit, you check their inflammatory markers, they have normalized now. And then you start tapering of the prednisone. You continue decreasing it every week or every 2 weeks. The patient now is on 20 milligrams, and you examine him. The patient is, nothing to indicate active disease, no symptoms. However, the labs show a rise in the ESR and the CRP. So what do we do in this case?
Vincent, one of our future rheumatologists, can help us.
Yes. When was that follow-up visit? Just a few months later, or?
Yeah, so we are following up with this patient. Let's say it's been a couple of weeks later. We've been tapering, and they were doing very well. But now this is the abnormality. I see as part of the routine workup, I'm seeing a rise in the ESR and CRP. It's very slight rise.
Right. I would definitely not go down on it because this patient will need long-term steroids for a long time. If it's just a slight rise and there's no correlation with other patients clinically, I would stay on the same dose and then reevaluate in a month, possibly.
Right. So this is where it becomes a little bit tricky because there are really no clear guidelines about how to proceed in this case. However, the general consensus among rheumatologists is that what we should go by are the clinical features. We shouldn't follow the inflammatory markers so closely where we make every decision depending on the inflammatory markers, right? So if this patient is doing very well clinically on exam, symptomatically they're completely normal, the prednisone has side effects, right? So our goal is to taper it as soon as possible. So I'll go by the symptoms in this case. The patient is asymptomatic, you continue taper. In this case, it can be a little bit tricky if you see the markers starting to increase, but I said slightly above normal values. So if they are markedly increased, I see that, you might want to hold there for a second, but if there is just a small increase in the inflammatory markers, I'll continue the taper because you want to reduce the side effects of the steroids as much as possible. So yeah, the correct answer here would be B. Now, what if there was a very large increase? Again, then it goes case by case. You have to look at the whole picture, but slight increase. And also remember that a lot of these patients, like I said, we're talking about an elderly age group, like they're in their 70s and their 80s. A lot of times you don't have the inflammatory markers when they were at their baseline, like maybe a few years before, right? So they could have had a slight elevation of ESR and CRP to begin with. And if you test the normal population, you might find a slight increase in the inflammatory markers. I wouldn't make a decision based on that, right? Okay. So as far as the treatment of GCA, the new guidelines for vasculitis treatment published in the American College of Rheumatology tell us that if somebody is diagnosed with GCA and they have visual loss, clear signs of severe disease in this case, you want to give IV pulse steroids. So you give Solomedrol, 1,000 milligrams, 3 days. And then you go on a 1 mg per kg, then taper afterwards. And then the new recommendation, and this is conditional. So a lot of these recommendations are not strong recommendations, they are conditional recommendations. So as far as whether to add tocilizumab, the steroid-sparing agent, which has shown to be efficacious in lowering, tapering the steroids faster than the placebo arm, who didn't have tocilizumab. Tocilizumab is effective, so the new guidelines recommend conditionally that you also treat with tocilizumab in addition to giving high-dose steroids. And in some cases, it might not be appropriate to give tocilizumab. Why? Because, again, like I said, these patients are elderly. They might have diverticulitis, for which tocilizumab will be contraindicated because there is an increased risk of GI bleeding with tocilizumab. So in those cases, you might think of maybe sodium methotrexate, azathioprine, depending on the case, right? If they have kidney disease, you wouldn't want to give methotrexate. So at that point, it becomes a little bit more complicated. But for your purposes, if somebody has symptoms of GCA, loss of vision, they should receive pulse steroids. If it's GCA without, and their vision is intact, then you just give 1 mg per kg of steroids and then taper from there. Or you can just do 60 milligrams and then taper from there. But, and then you can consider whether you want to add a DMARD afterwards. Again, that's usually at that point, rheumatology should be involved and manage the DMARDs, but just be aware that the goal is always to taper off the steroids as soon as possible and reduce all the potential side effects that come with high-dose steroids, especially for a longer term. Think of osteoporosis. So these patients should all be screened for osteoporosis and be treated if necessary. So get a FRAX score on all these patients. If you see them in your primary care clinic, make sure that any patient who's on steroids gets DEXA scan, calculate the FRAX. Don't just go by the T-score. Use the FRAX score to decide if a patient is going to be treated with anti-resorptive therapy or not. So any questions on management, on diagnosis so far?
Just to go back to the question in the chat, so Mantej had asked, does the use of steroids beforehand reduce the sensitivity of the biopsy?
So it does not within the first 14 days. After that, it starts to affect it, but in general, if it's done within 14 days, it should not affect the sensitivity. However, if you decide to do an MRI or an ultrasound, those within a week you can see changes. So again, MRA or ultrasound might not be the best way to approach it because MRA is not very sensitive in diagnosing GCA. Ultrasound, depending on the center and their experience with ultrasound, so and that's a different issue. But for biopsy, don't worry. Start treatment with steroids, and the biopsy should be done. Ideally, should be done within 2 weeks anyway. So in that case, should be fine. Yeah. Next question.
I don't see any more in the chat. If anybody has any questions about GCA, otherwise we could go ahead.
Okay. All right. So I have another question. Somebody else wants to read this?
Okay, I'll read it.
Great.
So, a 26-year-old Asian female is evaluated for a 4-week history of progressive dyspnea on exertion. She has experienced malaise and myalgia for the past 6 months, noting that her arms ache when she does physical activity with them. She was previously healthy. She reports no rashes, headache, or jaw claudication, gastrointestinal symptoms, or neurological symptoms. On exam, blood pressure is 120 over 60 millimeters of mercury in the right arm and 95 over 50 on the left arm. There is no rash, A reduced radial pulse in the left upper extremity is noticed. A grade 2/6 decrescendo diastolic murmur at the left sternal border is heard. The lungs are clear. There is no sign of itis. The strength is normal. CBC shows anemia. ESR is 90. Echo shows mild to moderate aortic valve regurgitation, dilated aortic root, normal valve leaflets, left ventricle dilation, and normal left ventricular ejection fraction. What's the most likely diagnosis? So here, so there are, this is a younger female and has symptoms of, basically there's a difference between the right and the left arm involvement, so that it's consistent with Takayasu arteritis. If this patient was older as the other case, then I will go for GCA. And then Kawasaki disease is more, like pediatric population, will present with MI or coronary artery aneurysm. So we'll have like the diffuse lymphadenopathy and rash symptoms at the beginning, and then the coronary artery involvement. And then IgA vasculitis, I'm not sure that they involve too much, like the extra renal vessels is more like GI and kidney involvement, but not on like the aorta, or like it's not a large vessel vasculitis.
Yeah, excellent. Yeah. So it's Takayasu arteritis, like I mentioned, is the age. They give you the ethnicity, Asian, right? And then you see the discrepancy in the blood pressure measurements, elevation in inflammatory markers, all those things point towards vasculitis, and in this case, Takayasu's arteritis. Okay. So the name goes by the ophthalmologist who discovered this, Mikito Takayasu. Again, the primary feature is pulselessness of the upper extremities. Again, it can affect the aorta, the branches, and there is a genetic component of HLA-B52. As we mentioned, young patients, they should be less than 40. Typically, it's described in Asians, but more recent reports are showing the prevalence is, you can also find it in the white population. So European studies are also showing similar prevalence. So this might change. Maybe since it was initially attributed to Asian population, maybe those patients were screened more frequently, but you can find it in any ethnicity. Females getting more often than males, about 6-to-1. So yeah. Other features, constitutional symptoms of vasculitis, right? You are thinking of malaise, the weight loss, low-grade fevers. Another feature is that it can affect the carotid arteries, right? You can get absent pulses, so make sure you check the blood pressure on both sides, and limb claudication. So if a patient exercises, they'll get claudication of those limbs that are involved, right? In this case, they can affect the renal arteries, so you might get hypertension. You can get joint pain, so arthralgias, right? Because it can affect the vertebral arteries as well, those patients can present with dizziness. And also something else that can happen is that you get subclavian stenosis. So if this is proximal, if the stenosis is proximal to the vertebral arteries, once you start exercising, all the blood flow will be in a way stolen from the vertebral artery. So you have somebody who exercises and all of a sudden they start getting dizzy, they fall. So this might be a sign that there could be a Still syndrome, right? From the stenosis that's proximal to the vertebral arteries. So it can affect the pulmonary vasculature. Patients can get angina. You can get aneurysms. So if we're thinking of GCA and even Takayasu's, it might be good to screen for aortic aneurysm. Some reports say that it might be worth checking even once a year for an aortic aneurysm. Again, this is not something that the ACR has confirmed that this is the usual practice, but there are reports that recommend that you can get mesenteric ischemia, rashes, So typical features of vasculitis, which can involve any vessel. Again, here we see on the image we have an MRA. So whether you get a CTA, MRA, or angiogram, the preferred modality is the MRA because there is less radiation. And you don't want to get an angiogram unless there is a plan to do a procedure. And maybe when you do a procedure, I guess the person who does the procedure, whether it's vascular surgery or IR, can consider getting a biopsy, but in general, you don't want to get a biopsy of these large vessels because there is a high risk of complications, right? So MRA, that is the preferred method, the preferred imaging method. And you can see this thickening of the wall vessel, stenosis. Sometimes you might see tapering where one region is tapered and there is the dilation. So put that together with the constitutional symptoms and that helps with the diagnosis. So the ACR tells us that you need three or more of the following criteria. Again, classification criteria are no diagnostic criteria. So these are patients used in for research studies, right? So remember, age should be less than 40, but what if a patient is 45 years old, or what if the patient is 50 years old? Can they have Takayasus? Yes. I mean, there are some things are not so clear in rheumatology. So although we say less than 4 years old, don't be limited by certain numbers. Remember, this is classification, is not diagnostic criteria. Look of the features, look of limb claudication, the decreased brachial artery pulse, the difference in the pulses, as we said. You suspect vasculitis of large vessels, get blood pressure in all four limbs, not just upper extremity, lower extremity as well. Look for a bruise, and so look for the aorta and the branches. So as far as workup, similar to GCA, we want to look for elevation in inflammatory markers. Although the inflammatory markers here are not as reliable as they are in GCA, if they are elevated, they help you. But if they're not, it doesn't really help. So if it's a case where it helps, might as well use it. Reactive thrombocytosis, which you see in most of inflammations, it's not specific, but it can be useful. Normocytic anemia, another feature of chronic inflammation. And the new guidelines, as we mentioned before, for GCA, we have also new guidelines for management of Takayasu. So once you've made the diagnosis, you want to start treatment with high dose glucocorticoids, typically it's 1 mg per kg or 60 milligrams of prednisone. And also the recommendation is, the goal is to reduce the amount of steroids that a patient will be subjected to. So it's recommended that you add another agent, a DMARD, which usually it's methotrexate, but you can use other DMARDs as well. You can use azathioprine as well. TNF inhibitors, questionable benefit, but they can be used as well. Again, by the point we go into DMARDs, that's a point where rheumatology should manage those DMARDs. But if you're suspecting vasculitis, I think it's okay to treat, right? And then as far as progression of symptoms, how often to check, is it every 3 months or every 6 months? Depends on a case-by-case basis, right? So there's no clear guidelines on the timeline of rechecking the imaging. But if the imaging shows any worsening, you want to go back to increasing the dose of steroids, and then at that point consider adding a DMARD if a DMARD has not been on board already, or if they have a DMARD on board, you might want to switch it to something else. So yeah. All right, so another question?
Fatma, do you want to read this?
Yes, sure. So we have a 21-year-old female with hypertension. She presented the ED with crushing left-sided chest pain, radiating to the left arm, associated with dyspnea and diaphoresis. Prior to onset of symptoms, patient endorses 7 months history of unintentional weight loss, fatigue, and generalized myalgia. On exam, febrile, blood pressure in the left arm 140/70 and 128 in the right arm. Brachial pulse is diminished in the right arm, and breathe is heard in the right supraclavicular fossa. Chest is clear to auscultation. Cardiovascular exam reveal bradycardia. No murmurs associated. Labs are notable. For elevated troponins and ESR. EKG shows ST segment elevation in the inferior leads. Echo normal segmental wall motion, mild AR, and aortic root dilation. Patient is admitted to the CCU and treatment for STEMI initiated. Angiography later showed irregularity of the coronary arteries with a large aneurysmal dilatation of the right coronary artery. In addition to the therapy of STEMI, what other medical therapy should be initiated? So I think the clinical picture of this patient is like more towards small vasculitis, small vessel, giving the coronary involvement, having constitutional symptoms, weight loss and fatigue. Her age, she's young. So I feel like it's much more going towards Kawasaki. And I think that treatment that I would say it will be still the IV methylprednisolone, giving like the acuity and severity of her condition.
All right, so one thing that, so you're thinking more of a small vessel vasculitis, right? Maybe the STEMI, I guess, kind of throws you off a little bit here, but remember the difference in the blood pressure, right? 140 on one arm, 128 on the other arm. What does that tell you?
That is middle vessel vasculitis.
It's large vessel vasculitis, right? We're thinking of large vessels that that give you this discrepancy. We're thinking of the age, right? 21-year-old female. So this is Takayasu, right? So Takayasu can also present with an MI, right? So it puts strain on the heart. It can affect the other vessels as well. It can affect the medium vessels as well. So the patient got a STEMI, but the age, the difference in the pulses, and the difference in blood pressure on both arms should give you the hint that this is Takayasu. And the treatment will be IV steroids, right? IV methylprednisolone in this case, because the patient is having a STEMI, right, from this condition. 20-year-old female comes with a STEMI. Absolutely needs IV methylprednisolone. 60 milligrams of prednisone will not be the appropriate treatment here. If it's an organ-threatening condition in general in rheumatology, that's when we give pulse steroids. If it's not organ-threatening, high-dose steroids, you can consider high-dose steroids, but once the diagnosis is of organ-threatening, you give pulse steroids, which is the treatment in this case.
So my question is here. You're right, I missed the part that there is a discrepancy between the upper limb blood pressure, but if it extends to the coronaries, which is like small vessels.
Yeah, so coronaries, that's more like medium vessel. Small vessel, we're thinking more of
Kidney.
glomerulonephritis, for example, but in this case, we have upper extremities, right? So maybe it's the subclavian, maybe it's the axillary here that's involved, which gives you this discrepancy in those blood pressure, and it can also affect the medium vessels.
Okay, thank you.
All right, and that's all, guys. You have any questions for GCA, Takayasu? I mean, GCA, you should definitely try to know it well, because this will definitely, you'll definitely see a patient at some point with GCA. And definitely get used to ultrasound. I think this is the future. I think it's becoming more and more important to be well trained in ultrasound for GCA and for any other conditions. So, yeah.
Thank you, Dr. Koci. Does anybody have any questions about large vessel vasculitis?
I have one question for the GCA. The biopsy, if the patient asks us about the biopsy, how it's taken, is this like invasive or non-invasive outpatient procedure or not?
Yeah, so I'll let you know from my experience, the biopsy, whether you do it within 3 days, whether you do it inpatient, or whether you do it within 14 days, like we said, you have 14 days where you can do the biopsy and it won't affect the sensitivity. So this should be urgent cases for vascular surgery to schedule and complete them outpatient. The patient, if you think the patient might have GCA, I guess if you think of a primary care point of view, I can see where you might think, should I have this patient admitted so that they can be seen ASAP by rheumatology? But I think from my experience as a rheumatologist, if I think somebody has GCA, I give them high dose steroids. I get in touch with vascular surgery to make the appointment ASAP. And the prednisone will make the difference. The biopsy is there. Once it's negative, I can just stop the steroids. But if a patient is on steroids for a few more days, it's not the end of the world, right? It can save their vision. So give the steroids, and then the biopsy can be done within 2 weeks outpatient. It doesn't have to be, the patient doesn't need to be admitted for GCA. But if they have loss of vision, then obviously you should admit them. Ophthalmologist should see them, because there might be something else on board. It might not be just GCA that you're treating at that point. Maybe they have a stroke as well.
An additional question, do we, in practice here in our hospitals, do we do ultrasounds for these patients?
I'm relatively new here, so from what I heard, you can do an ultrasound. Ultrasound should be made. You can order an ultrasound of temporal arteries and axillary artery, but we still need the biopsy. So it's not, I guess we need more ultrasound. And myself, we're trying to get an ultrasound here, so I'll be doing more scans with ultrasound, but I personally haven't most rheumatologists have not been trained to use the ultrasound to diagnose GCA. The vast majority, I'd say.
Thank you. Any more questions from anybody before we head for a break? All right, I think we're good. So thank you, Dr. Koci. Thank you for joining us.
Thank you, guys.
Pleasure. And for everybody else, we'll take a break.